Hello, I'm Jeff Birch. I'm here today to describe a method for assessing the relative positions of the joints in the human leg. This is a developmentally based component that I'll describe of how the joints sit with respect to each other. It's very important for assessing realistic goals for alignment and movement for people. I will talk about this at a little more length, and then we'll work on a skeleton to show you how to do it, and then I will make the same assessment on each of Damien's legs. Each leg, because the two are never the same in each person. So in we have several different kinds of joints in our bodies, and knees and ankles are what we call hinge joints. Much like a finger joint, they have really one axis that they move on. They don't do much other than flexion and extension. But the interesting thing is that the axis of the knee joint and the axis of the ankle joint are only rarely actually parallel to each other. They're usually not parallel to each other. And for the developmental piece of that, at birth, if we're looking at the person from the front here, the ankle joint is usually internally rotated about 10 degrees at birth. And then during growth, during childhood growth, the tibia twists along its length. So usually at about 5 or 6 years of age, the two are briefly actually parallel. And then the journey continues so that by maturity, each ankle joint is externally rotated with respect to the knee joint. Anything from 5 degrees to 18 degrees per leg is considered normal, but sometimes it's less than that, and sometimes it's more than that, up to 25 degrees. I have seen a couple of people whose tibias made none of that journey. In adulthood, they were still 10 degrees internally rotated. There's a similar developmental torsion that occurs in the thigh bone and the femur, but we have to think about that a little differently because the hip is not a hinge joint. So what you can do is to put a plane through the greater trochanter, through the center of the ball, and down through the center of the femoral shaft. And if you extend that plane down to the knee, the question is the axis of the knee joint a hinge joint in that plane or not? And usually at birth, what you have is the knee joint internally rotated 30 to 40 degrees with respect to the hip joint. And then much like the tibia, during growth and development, as the femur lengthens, it twists along its length, so that usually in adulthood you have 10 to 15 degrees of internal rotation there. But it could be more, it could be 20 degrees, or it could go all the way to externally rotated up to about 8 or 10 degrees out there. That's considered not so normal to be out there. The 10 to 15 degrees of internal rotation is considered normal. Now, we also have how the hip joint socket faces on the pelvis. If you look at this pelvis, you'll see that the hip joints don't face straight out laterally. They are pointed toward the front a little bit, and that's typical. So 13 to 20 degrees of facing a little more forward is considered normal, but sometimes more than that. And occasionally they are actually parallel, and more rarely they actually point backward a little bit, up to 5 or 10 degrees backward like that. And so we'll talk about how to assess that position. So for considering where each individual's feet would be in an easy neutral, you have to take into account how does the socket face? How is the plane through the top of the femur related to the axis of the knee joint? And how do the axes of the knee joint and ankle joint relate to each other? So we're going to document that for each leg of the skeleton and each of Damien's legs here to show you a process for doing that. All right, let's move over to the skeleton, and I'm going to show you this for the lower leg first. So again, the knee joint is a hinge joint. We hope that there's no forward-backward shear in it. We hope that there's no side bending in it. It's just a hinge joint. Ditto for the ankle. Now, you can make your foot go around in a circle, but any component of that, other than the up-down point, is movement farther out in the foot. The only thing the ankle joint itself does is flexion and extension. Okay, there's a wee bit of forward-backward slide in it, but basically up-down. Now, in order to find out how these two axes relate to each other, first thing we want to do is get the axis of the knee joint so it's parallel to the table surface. We're going to use the table surface as our reference for this. So if I just flex the knee, what we see is this one slightly is angled in. So I'm going to put my hand under the knee, I'm going to roll it out a little bit, and now I'm going to pick it up again. And I overshot a hair there, so I'm going to go back a degree. And now when I flex it, it comes up perpendicular to the table. So I'm going to maintain the knee in this orientation, and I'm going to get a hold of the talus. It's important you get a hold of the talus because that's one of the bones of the ankle. If I'm farther out here, I've got too many joints in between. I want to know about this one. So now what I see is that this foot is just a wee bit externally rotated here. So this is essentially the low end of normal. That's about 5 degrees of external rotation on this leg. All right. Well, let's think about the femoral torsion. Again, we don't have a hinge joint here, so what we think of instead is a plane which runs through the greater trochanter, through the center of the ball, and down the center of the femoral shaft. And our question is the axis of the knee joint in a continuation of the same plane, or, as is normal, a little bit internally rotated, or possibly slightly externally rotated? So, just like we wanted to get the axis of the knee joint parallel to the table, we want to get the this plane through the ball and the greater trochanter parallel to the table. Now, I can start to determine where this sits if I push in on the greater trochanter straight in and see how it externally rotates. That tells me that it's already a little bit externally rotated, so when I push on it, it goes more that way. If it had internally rotated, it would have told me that this was sitting not parallel to the table, but a little bit forward like that. Okay, so I'm going to roll this femur in a little bit, and now I'm going to push in, and now it's just solid. It just goes in. So I'm going to maintain this end of the femur parallel to the table like this. This is now a stabilizing hand. And I'm now going to flex the knee, and you see how it goes medially? And so again, that's sort of low normal in there. That's probably 15 degrees of internal rotation right there. All right, next piece. How does this socket face? Again, the socket faces a little bit faced toward the front, but rarely they will be parallel, and occasionally, and a little bit abnormally, they may be a few degrees posteriorly faced. So to find out about this, what we're going to do is internally rotate the femur as far as it'll go, and hopefully to a bony end feel. And so we're going to notice where that goes, and then we're going to externally rotate it to a bony end feel, and we're going to estimate a midpoint between those two. And this particular skeleton, this appears to be maybe 5 degrees rotated to the rear. So this one's a little abnormal in that sense. Now, I mentioned that this needs to be done to a bony end feel. When I'm trying to take it this way, if I don't have a nice solid end, if I've got some kind of softer end to it, there's some version of a soft tissue issue here where I can't really find where the end is, so I'm less able to accurately do that. The very best way to determine how the socket is facing is with an MRI, but I'm giving you a manual therapy approach that will usually make a fairly good approximation of that. All right, so let's put these bones away. Once you come lying back on the table, let's let your heels be just off the end. So what will we find? You never know. Life's always an adventure. Just lying here, it appears that this knee is more pointed outward. However, I wish to point out that kneecap position is not a reliable indicator of where the axis of rotation of the knee is, because the knee can be held by soft tissue, either medial or lateral. So I'm going to put my hand underneath and just bend it. And indeed, it does come up a little bit to the outside, although not as much as the kneecap would have suggested. So we're going to rotate the leg in a little bit. Try again. That's better, but let's go 1 more degree in. And now it comes up perpendicular to the table. Then I get a hold of the talus. Remember, you must get the talus not farther out on the foot. And we'll move the talus in the mortise. And much like our friend the skeleton, what we have is low normal, about 5 degrees of external rotation. I'm going to make a note about that. All right. So now let's get the head of the femur, the top of the femur, parallel to the table. So if I find the greater trochanter and I just push it in, it immediately internally rotates, which tells me it's at the moment sitting a little bit internally rotated. Fine, let's externally rotate it a little bit from there. And again, try pushing this in, and it still rotates in. Okay, let's go a little bit more this way. Aha, there it goes straight in a solid. So I get to hold this top of the femur actually significantly externally rotated from its resting position there. And now, if we flex the knee, you can see that it comes up also significantly externally rotated. So you have a less common situation that the rotational journey in your femur went farther than average for that. Okay, well, let's try to get a read on how the socket is sitting in here. Are they the typical sitting a little bit pointing forward, straight out? The less common pointed a little back? So I'm going to make some stabilization of the pelvis from here, and we'll internally rotate as far as it'll reasonably go, and then we'll go the other way. And there's the end of the road that way, and they are nice bony end feels both ways. So there's about halfway in between the two, and indeed that is sort of low normal pointing anterior there. All right, let's go do it all on the other side. What will we find? You never know. So similar to the other leg, this knee appears to be pointing a little bit outward, though perhaps less than the other one did. Let's see what happens if we flex the knee right where it is. And it turns out to be not as externally rotated as I would have interpreted, again, from looking at the kneecap, but a little bit. So we're going to roll it in a little bit. And there we come pretty straight up like that. And now down here at the ankle, that's more like 15 degrees of external rotation. So this was low normal, and this was toward the high end of normal for external rotation there. And that sort of difference is completely ordinary. All right, here we go with the hip. If I just try to find the greater trochanter, if I just try to push this one straight parallel to the table. Oh, what fun, it externally rotates. Okay, so we're going to roll this one in a hair and try that again. And now it internally rotates a little bit, backing up a little bit. There, we've got it solid for straight in. So maintaining the top of the femur right here, bringing the knee up, that is very close to straight up. Okay, so we've got a 0 degree there. What will we find with how this acetabulum faces? You never know. Here we go. So attempting to internally rotate this one, the good news is we've got a bony end feel right there. And we go the other way, we've got a bony end feel. Interestingly, neither excursion is terribly far, which suggests to me that this is a relatively deep socket. Some people's hip sockets are deeper than others. And the trade-off is stability versus range of motion. So this doesn't look anything like a hip dysplasia hip over here, where we'd have, whoa, too much range of motion. But this may be a little bit deeper socket than the other one was. And again, that's completely ordinary. So, internal rotation, external rotation, halfway in between. So that's just about straight ahead. Okay. There we go. All right. So in the right leg, the socket here appeared to be 8 degrees rotated in, 8 degrees rotated out, and then 5 out. So the sum of that would be like about 5 degrees out. And on the left side, we had 0, 0, and 15. So 15 out would be the sum of that. And just lying here on table, your left foot is more externally rotated than the other one. And that would be completely normal for you for standing. All right. Tell you what, come on up to to standing is the camera there, so that your feet fall where it's kind of easy. And I'm curious, you can see how your left foot sits a little more externally rotated, which we just determined for you is right where it belongs. There are good things about having feet a little bit externally rotated. Some disciplines want people to have your feet parallel. One of the advantages of standing a little bit turned out is that gives you a broader base of support, more stability. And also, if I want to start walking not straight ahead, but in a turn, if my feet are parallel, I have to pick a foot up and put it over there to go. Whereas if I'm already a little turned out, I can just go with it. So we know where what's to be the happy place for your feet. So if I were engaging in soft tissue work here, I would want to assist you to have your muscles accommodated to do what the bones are. It looks like for you, they're fairly well with that already. And then as we look at what movement patterns, we could, again, I could provide you with some coaching to find ease in your body as you move. All right, there's the process. Thank you very much.